Hello everyone, welcome back to my channel. So today we are going to discuss about approach to hematological abnormalities, and in this context we will be dealing with how to diagnose anemia, how to classify anemia, how to classify whether the anemia is regenerative or not, and we'll also be learning how to know about effective erythropoiesis and basic CBC interpretations and all about anemia. So when you take the CBC, you have so many parameters that the machine will give. The most important parameters are hemoglobin, PCV, MCV, MCH, MCHC, RDW. These are the most important parameters that helps us to diagnose and differentiate what type of anemia it is. Mostly anemia is broadly classified into three based upon morphology, which is like microcytic, normocytic, macrocytic, and based upon hemoglobin concentration, it can be differentiated as hypochromic anemia and normochromic anemia. And based upon amount of reticulocytes that you notice in the blood smear, you will be able to differentiate whether the anemia is regenerative or not. So absolute reticulocyte count, in order to determine absolute reticulocyte count, you need to estimate the reticulocyte percentage and multiply it by total number of RBCs and multiply it by 10. And corrected reticulocyte percentage is equal to reticulocyte percentage multiplied by the PCV divided by the average PCV. For example, for dog it is going to be 45 and for cat it is going to be 37. And coming to RPI index, which is called as reticulocyte protection index. So reticulocyte protection index is equal to corrected reticulocyte percentage divided by reticulocyte maturation time, where reticulocyte maturation time is the time taken by bone marrow to release reticulocytes in order to compensate the anemia in the peripheral smear. You need to remember that reticulocyte maturation time is inversely proportional to the PCV. If the PCV is really low, then RMT will be longer. If the PCV is really high, then RMT will be shorter. And RMT is denoted in days. PCV of more than 35%, then the reticulocyte maturation time is going to be 1 day. If the PCV of our patient is going to be somewhere between 26 to 35%, then reticulocyte maturation time is going to be 1.5 days. And if the PCV is 15 to 25, then RMT is 2 days. If the PCV is less than 15%, then RMT is 2.5 days, which means it takes 2.5 days for bone marrow to mature and release the reticulocytes in order to compensate anemia that has PCV of 15%. When you use this formula to calculate RPI index, you will end up with the results starting from 0 up to 4 or 5. Based upon the numbers, the interpretation is here. If the RPI value is somewhere between 0 to 1, then the interpretation is no response from the bone marrow. Only when there is non-regenerative anemia, you will find RPI index coming between 0 and 1. If the RPI index is between 1 and 2, then it means that bone marrow is able to respond, but it is not adequate. It's a poor response. If the RPI index is between 2 and 3, then the bone marrow is actually responsive, which is good, but the responsiveness could be due to hemorrhage or ongoing hemolysis. If the RPI index is more than 3, It is responsive and always indicates that the anemia is due to hemolysis. So, when the anemia is regenerative, then you will actually see these changes in the blood smear. You will see Haemolytic bodies. They are like a small basophilic inclusion bodies in the within the RBCs. They are little larger in number. They are little larger in size, and you will see polychromasia. Polychromasia is nothing but immature RBCs that are released from bone marrow. They are not pink in color. Usually RBCs are pink in color, but they have mild tint of blue in them. That's why they are called as polychromatophilic erythrocytes, and they are usually little larger in size. That's why in regenerative CBC you will see increase in number of RTW and MCB. And basophilic stippling can also be seen in regenerative changes. Taurocytes can also be seen, and nucleated RBCs can also be seen in regenerative smear. Actually, you need to compare nucleated RBCs and polychromatophilic erythrocytes and Haemolytic bodies to determine whether the anemia is regenerative or not. But in case of non-regenerative anemia, generally the RP index is going to be 1 or less than 1, and the blood picture is going to be normocytic, normochromic most of the time, but sometimes it can be microcytic as well. But in blood smear you will not see nucleated RBCs or polychromatophilic erythrocytes, and in CBC you won't see increase in reticulocyte numbers as well. Coming to anemia of chronic hemorrhage and iron deficiency, the blood picture you see is microcytic hypochromic anemia with hypochromic leptocytes in the blood smear examination. And whenever there is chronic hemorrhage, you will see low plasma protein, because when there is blood loss, you will not only lose blood but you will also lose proteins. That's why you will actually see low plasma protein. And along with chronic hemorrhage, you will notice thrombocytosis. But this is not true in all cases. You will actually see thrombocytopenia as well. I'll explain you why. When there is hemorrhage, more platelets will be recruited to go and form clots to arrest hemorrhage. So what happens is there will be shift of platelets from blood circulation to that particular area. So bone marrow will produce more thrombocytes in order to compensate the total number of platelets in the circulation and also to stop the bleeding. So thrombocytosis. But why thrombocytopenia? Because the same, when there is active bleeding happening inside the body, more platelets will go and start forming clots in that particular area. What happens is platelets will be consumed by hemorrhage, so you will see consumption thrombocytopenia. That can also be seen in chronic hemorrhage. And coming to reticulocyte counts will take some time to increase, and once they increase they will be high for some amount of time. But if the anemia is chronic, or if the internal hemorrhage is chronic and it is happening in small amounts, the reticulocytes will start to decline. Why? Because bone marrow will be exhausted because of constant recruitment and release of immature erythrocytes, and chronic anemia and chronic hemorrhage at constant rate will deplete iron stores from bone marrow and from the liver. So it will lead to iron deficiency. and in bone marrow iron reserves will be drastically reduced, and myeloid erythroid ratio will be altered. Why? Because normally in animals myeloid erythroid ratio is somewhere between 1 to 2 or 2 to 3 is to 1, but when there is anemia of chronic hemorrhage or iron deficiency, there will not be effective erythropoiesis, because erythropoiesis is directly proportional to iron stores. If the iron content or iron stores are drastically reduced, then erythropoiesis will also be affected. It is directly proportional. So there will be ineffective erythropoiesis, which will cause erythroid hypoplasia, and that is going to alter the ME ratio in the bone marrow. So how to diagnose anemia of chronic hemorrhage and iron deficiency? All you need to do is estimate serum iron levels, serum ferritin levels, and you need to do a test called total iron binding capacity, and you also need to estimate percentage iron transferring saturations and bone marrow hemosiderin stores. TIBC estimates how much transferrin is able to effectively bind with the iron, because iron binding is really important. If the iron binding is not adequate, then it can lead to iron deficiency anemia, or if the transferrin protein itself is less in circulation, then again it can cause iron deficiency anemia, which will be commonly seen in liver diseases. Especially if there is functional liver disease, you will see low ferroproteins transferrin, which can cause TIBC levels, low TIBC levels, which can lead to iron deficiency anemia. And in bone marrow, you will see drastically reduced hemosiderin stores. And coming to hemolytic anemia, the most common hemolytic anemia you see is immune mediated hemolytic anemia, and again it can be further classified into primary hemolytic anemia and secondary immune mediated hemolytic anemia. Primary IMHA is due to production of autoantibodies that are going to destroy its own erythrocytes. Secondary IMHA is triggered by infections, ongoing infections. For example, FELV and Mycoplasma haemophilus in cats, and in dogs, Babesia canis and Babesia gibsoni can cause secondary IMHA. And there is another type of anemia due to oxidative damage, and in that type of anemia you will see profound increase in Heinz bodies and eccentrocytes. Eccentrocytes are commonly seen because of oxidative damage to the erythrocytes, and this type of anemia can be commonly seen in onion toxicity, zinc toxicity, and acetaminophen toxicity as well. And there is another type of anemia which you can also call it as a paraneoplastic anemia, paraneoplastic hemolytic anemia, which is called as microangiopathic hemolytic anemia, which is happens commonly due to hemangiosarcoma, where the blood vessels are not smooth, they are rough. So what happens is, when the RBCs are passing into the blood vessels, it gets ruptured, mechanical trauma happens, and that is going to cause hemolytic anemia. Then some tumors are associated with hemolytic anemia, and that is malignant histiocytosis, which commonly affects bone marrow, and it's pretty commonly seen in golden retrievers. And there are inherited red cell defects that can also cause hemolysis, because our immune system don't like to encourage abnormal erythrocytes in the circulation. When they see abnormal erythrocytes with different shapes or size, and when they have different antibodies on the surface, they just attack and destroy the erythrocytes. And this is really bad when a patient has inherited red cell defects, and such patients will need lot of blood transfusion throughout their life. And severe hypophosphatemia can also cause hemolysis because RBCs are made up of lipid bilayers, and if there is hypophosphatemia, erythrocytes are very fragile and they are prone to get destroyed by minimal wear and tear, like minimal force, so that can also cause hemolytic anemia. So how to actually diagnose immune mediated or any hemolytic anemia just by seeing CBC and biochemistry results? Here I'll show you. If you see blood smear, it is going to have moderate to severe anemia. You understood? It is going to have polychromasia, it will have profound increase in nucleated RBCs, and you may see microcytic hypochromic or normocytic hypochromic blood picture. You will see profound reticulocytosis. In CBC, you can see moderate to severe anemia with pre-regenerative state. So what is pre-regenerative state? It is a state between the event where anemia happens and response to anemia. So for example, today the dog had a trauma and it has severe internal bleeding. So when there is internal bleeding, there is going to be hypoxia in the system. That hypoxia is going to be sensitized by our kidneys, and kidneys will go crazy and they are going to secrete erythropoietin, and this erythropoietin will go and act on bone marrow to ask the bone marrow to produce more erythrocytes. That happens in two mechanisms. It accelerates the release of immature erythrocytes into circulation, and also it accelerates the maturation of erythroblasts to erythrocytes. These are the two mechanisms involved. So the whole process takes some time. That state is called as pre-regenerative state, where in CBC and peripheral smear you won't see any signs or any clues regarding regeneration. Like you won't see polychromasia, you won't see nucleated erythrocytes, and in CBC you won't see changes related to regeneration. That is called as pre-regenerative state, and it is usually 2 to 3 days in small animals. So whenever there is anemia, you need to actually wait for 2 to 3 days to see an adequate response to anemia. Before that, you should not conclude the anemia as non-regenerative. And in hemolytic anemia, we all discussed about RPA index. The RPA index will always be more than 3. This high score always directly correlates to hemolysis. And in blood smear, what do you see? You will see anisocytosis. Why? Because there is accelerated release of immature erythrocytes and polychromatophilic erythrocytes. They are larger than mature RBCs. Okay, so anisocytosis is there, and because of anisocytosis in CBC, you will see increase in RDW value as well. And in blood smear, rarely you can see spirocytosis as well. We have noticed spirocytosis very commonly in cocker spaniels that have IMHA. And spirocytosis, if you spot 1 to 2 spirocytes per high power field, that doesn't directly correlate with IMHA. You need to see actually 5 to 10 spirocytes to conclusively suspect IMHA. And you can also do autoagglutination test within the laboratory. It's a simple test. There are 2 types of autoagglutination test. One is saline agglutination test. You just put a drop of blood and 2 drops of normal saline. You mix and see for agglutination grossly and microscopically. There is another autoagglutination test where you actually wash the erythrocytes and extract the serum of the same patient, and you just incubate the serum of the patient and washed RBCs for 45 minutes at room at 37 degrees Celsius, and after that You need to examine that sediment under microscope to see agglutination. If you see agglutination, then it suggests IMHA, because if there are more surface antibodies, there is going to be agglutination reaction happen, and that will also give you some clues to diagnose IMHA. And in leukogram changes, you will see left shift with toxic neutrophilia. See, this toxic neutrophilia doesn't always indicate some inflammation. It is also a response of hypoxia. And you will also see prehepatic jaundice because of accelerated hemolysis that is happening in the system. And because of this, you will also see plasma or serum not pale, not transparent. It will be really rose red to hemorrhagic in appearance, and urine will also be pigmented. You will see hemoglobinuria and hemoglobinemia. Fine. And this is the diagram to explain the pathophysiology from a normal bone marrow, normal blood smear, to how regenerative anemia becomes non-regenerative anemia. We are going to see all the mechanisms in this one diagram. So this is the rectangular box. This rectangular box is red in color, but it becomes paler and paler in color. You need to note this. Here, if you see here, bone marrow, RBCs and peripheral blood, they are normal. They are in equilibrium, physiologically normal. So they are bright red in color, which means there is no signs of anemia. But there is an event happens. The dog or cat gets hit by a car, or it gets a severe infection or immune mediated hemolysis where there is accelerated destruction of RBCs. Okay, so what happens is, because of excessive destruction of erythrocytes, systemic hypoxia will happen, and systemic hypoxia will be sensitized by the kidneys, and kidneys will produce erythropoietin, and erythropoietin will act on bone marrow, and bone marrow will be asked to produce more erythrocytes, right? So marrow cells are under the influence of erythropoietin, and they are producing more erythrocytes. That's why hyperplasia happens. In bone marrow, you will often see erythroid hyperplasia. When erythroid hyperplasia happens, concurrently in blood smear, you will see regenerative changes like polychromasia, increase in number of nucleated RBCs, and in CBC you will see high RDW, and you will see high MCV. It's all because of regeneration. But for example, another case scenario, the dog that has multiple GI ulcers due to chronic NSAID toxicity, and it has developed many ulcers in the GI system and in the stomach. What happens is, the dog is experiencing chronic blood loss from ulcers. In this case, it is happening for over 6 months. Then what happens is, the iron stores in the system and in the bone marrow will be exhausted, because in order to compensate anemia, bone marrow will keep producing more erythrocytes, but at one point it will stop. That is the point where erythroid hyperplasia will become erythroid hypoplasia. When there is hypoplasia of erythroid precursor cells, you will see non-regenerative anemia in peripheral blood smear, which means you won't see nucleated RBCs or polychromatophilic erythrocytes. But if the chronic hemorrhage is not addressed, and if it progresses for even longer period of time, then it ends up in a condition called pure red cell aplasia, where in bone marrow you won't see erythroid precursors nor iron stores. This is a very bad condition. So that's why you are seeing paler color in this rectangular box. Coming to the immune mediated hemolytic anemia, the immune target can be against two cells. It can be against mature RBCs, it can be against immature RBCs in the bone marrow itself. If the immune target is against mature RBCs, which is in the peripheral blood, peripheral destruction happens. But since the bone marrow is normal, it is not affected by immune mediated attack, it will keep producing more erythrocytes, it will push more erythrocytes in the circulation, and the anemia will be compensated. But if the immune target is towards immature cells and mature cells, then it becomes really a nightmare. Why? Because when there is immune mediated attack on immature erythrocytes, then even in the bone marrow, immature cells will be destroyed in the same rate of mature cells. Then anemia will not be regenerative anymore, because no cells are produced, cells are dying within the bone marrow. Then it results in a non-regenerative anemia state. Coming to the diagnosis of hemolytic anemia, if you have an in-house laboratory, you can go ahead with two types of agglutination test, saline agglutination test and auto agglutination test. And if you have Coombs test kits, you can do direct antiglobin test to diagnose immune mediated hemolytic anemia. And you will often see thrombocytopenia in 65% of cases with IMHA. And whenever there is hemolytic anemia, you always should rule out infections like FELV, mycoplasmosis, babesiosis. PCR is often advised, because to treat IMHA, if you have ruled out everything and you have diagnosed with IMHA, the treatment is going to be steroids. If you haven't ruled out underlying infection, then it will make the situation really worse. In order to diagnose FELV, because FELV is this virus likes actively dividing cells, they tend to often go and settle in bone marrow. So we have seen many cats that has come positive with FELV PCR from bone marrow aspirate, that and all those cats showed typical signs of pancytopenia and some signs of myelodysplastic syndrome, non-regenerative anemia, etc. So whenever you are suspecting for FELV infection, you can go ahead for bone marrow core biopsy and send that core sample for FELV PCR. It will definitely help to rule out FELV infections in cats. And bone marrow aspiration is not generally recommended, because when there is ongoing anemia, any sort of anemia, you will definitely see erythroid hyperplasia. So it's just an optional thing. Unless you have concurrent thrombocytopenia and you want to roll out some chronic ehrlichiosis and other infectious agents, etc. And in hemolytic anemia, you will see elevated globulins and low AG ratio. Why? Because all antibodies are generally globulins, so definitely they are going to be high. You can also do a serum protein electrophoresis or serum protein immunoelectrophoresis to see which immunoglobulin is high and predominant. So that can also help you to diagnose anemia, hemolytic anemia. So this is a nice picture that is taken in our laboratory, and this was a simple saline agglutination test for a patient that was suspected for immune mediated hemolytic anemia. You can see a large number of erythrocyte agglutination here, and this strongly suggests immune mediated hemolytic anemia. And if you see the blood cells, there is anisocytosis, right? So this cell is smaller, this is bigger, and you can see marked anisocytosis even in simple agglutination test, and these are strong agglutinations. You can always differentiate an agglutination from Role formation by adding normal saline. If you add normal saline, the Role formation will disintegrate and it separates into individual RBCs, but if it is an agglutination, it will remain just like that. So that will also help you to differentiate, especially if you are starting to see all these things. Yeah, and this is a 4x magnification of bone marrow aspirate, where you can see hemosiderin ion stores, this brown to black spicules, these brown to black aggregates are hemosiderin ion stores. You ideally need to see a lot of these in bone marrow core aspirate. This will indirectly tell whether bone marrow has adequate iron stores or not. So this video ends here. So we have covered basic CBC interpretation and how to differentiate a regenerative anemia and non-regenerative anemia. We did see in detail how to do an RPA index, and we saw different type of hemolytic anemia and regenerative anemia and all its like changes that you see in bone marrow biopsy, etc. In next video we will discuss in detail about primary bone marrow disorders, bone marrow suppressions, and other causes of anemia in detail. Thank you so much for watching.